I'm a retired neurosurgeon, and I still working to learn what is going on the human body. And I'm a PhD student in the anatomy department of Ankara University. It is quite famous and traditional, a little bit. This drawing is coming from Da Vinci. I didn't understand very well. Maybe we can ask. Why destructive pain surgery? Why surgery for pain? We could say that we knew in the new age, this age is science age, and this age, advancement medical technology, average lifespan is high, degeneration and cancer incidence is high, all the medical budget is going to increase in everywhere, and medicine is a social problem, and pain is a social problem too. Medicine is a social problem, I said. Do we know the human beings properly? Pain in the cancer patients, 30 of cancer patients are in pain when diagnosed. In the early period, it is 35%. It's in the 74% in the advanced state. It is 90% in the late period. Late period, it's a great problem. What can we do for a cancer patient? Nothing, I believe. Can they sleep well? Can they drink warm soup at dinner? I have seen some of the Turkish people living here, listening here. Can they sleep without pain? Could we say yes? In the cancer incidence in all over the world is increasing. Now it is about more than 20,000 million people cancer. In 2003, it is 6.6 million cancer patients. It's increased in 2009, 17 million cancer patients. 5 million will die with pain or not, probably in this year. Could we use this? Arrange this? Is somebody help me? This is the pain transmission system. We are going to making the lesions here. We have a problem in the system. I cannot demonstrate to you the conduction of pain transmission. Now I'm going to talk to you about the concept of the neurosurgical pain practice. First, efficiency of the procedure. Is it efficient or not? Second, quality of life after the procedure application. And the third, the cost of the procedure. Is it cheap enough? Is it efficient enough? Classical visualization method of the destructive pain surgery was X-ray. With CT guidance, it is possible to measure diameter of the spinal cord at the lesion level. And since 1986, I am using this procedure with CT guidance at the CT unit. And it is possible to making the lesion in the special part of the pain conducting system. It's possible to make the selective coronotomy or extramuscular mylotomy or selective trigeminal tractotomy for me. We use too many methods. Why we prefer to destructive pain surgery? We use stimulation and implantation. These drawings making by a special artist in a 1 second. I described the problem and he made this in a 1 second. This is the implantation. We are going to give the electrical stimulation. We are going to give the drugs inside of the tissue, inside of the target organ. Consider that this is the non-invasive method, and it is so popular because the company pushing these procedures properly. It is only problem is it is expensive. It is not easy to tolerate the stimulation system. Have you been in the line of the waiting list in the hospital? The doctor is in the outside, people said. One day you can see one doctor, another day you can see another doctor. This is not good. Could we do something?
Disconnection and presentation?
Yes, probably. We use the ablation. Ablation is wrong. It is, we are going to make the destruction. Ablation is removing something. It is correct for epilepsy surgery. We use computer tomography since 1986, routinely in the procedures. Since 1987, CT-guided destructive pain surgery has been routinely used in the Ankara University and private practice of the author. Stereotactic pain surgery is performed in 3 stages. One is localizing the target point with stereotactic methods or imaging. It is possible to obtain by X-ray or CT or MRI guidance. 2 measurements of the resistance of the target point and stimulation with the stimulation. And finally, we are going to make the control and selective dissection of the target point or tissue. I like to use the radio frequency. Could I have? This is published in Neurosurgery, 3 different articles. It's collected for me in the United States. It's possible to share it with, you can say it to Tolgay, and this is the knowledge. It's necessary to share with everyone. In the stereotactic neurosurgical pain procedures, the morphology is very important, neurophysiology is very important. We can use impedance measurements, evok potential and stimulation. And finally, first we are going to demonstrate the target, and we evaluate the target function with impedance measurements and neurostimulation. And we are going to make it the control target. We are keeping the bird in our hands. If we push too much, we kill the bird. If we make a little bit free, it's escape the bird. We are not going to escape the bird, and we are not going to kill the bird. I will talk about the first procedure, was cordotomy. This is a special slide taken by you can see tuberculous granuloma here. This is the wonderful picture of Spiller. Spiller is very wise neurologist. And in the other side, they describe the patient described the pain diminish. Pain, now no pain over there. And after this, he forced to the Surgeon Martin. And Surgeon Martin was performed the first cordotomy in the paraplegic patients. And later, it disappeared, the pain problem. The cordotomy started with the open procedure just after this experiment. Open procedure was performed in the cervical and thoracic region, and it's described by the percutaneous method in the Rozomov and Molan. I have met both of them. Molan is alive or dead, I don't know. But Rozomov died, 1 year before. And Lin and Gildenberg make this procedure anteriorly by transvertebral approach, interspace, with special needle. And since in 1987 we are doing this procedure with CT guidance. I have 224 cases. And it's worked very well, 42. Most of the cases are malignancy patients, cancer patients. No mortality and very limited morbidity. I can say that I have more than 5,000 cases with radiofrequency lesioning, and I have no mortality also. Mortality is very important point. Morbidity is very important point also. Now I'm going to show you a special destructive procedures here. This is central cord area. We don't know what is going on in this area, but if we are going to make a lesion here, we named extralemniscal Here is cordotomy. Here is trigeminal tractotomy. Here is the nucleus caudalis dress operation, and dress operation is here. You can use all of these by my permission, because this is science. It must be shared. You can get it free. First procedure we started with extralemniscal myelotomy. I tried to make the lesion 3 times in the one patient, first patient. It was not work at the beginning, and it's worked later and later. The third time I succeeded. I have not too much cases, 19 cases, 21 procedures. They reported initial pain relief some people have special pain relief in this group of patients. I can talk you about the trigeminal tractotomy nucleotomy. We are going to lesioning of the descending trigeminal tract. Nociceptive pain fibers stay in this tract, 5th, 7th, 9th, and 10th. And this tract also has the substantia gelatinosa. I'm sorry. It is not very well designed. Trigeminal tractotomy, we are going to make the lesions in the descending trigeminal pathway. I have 81 patients, 96 procedures in this group. The pain relief is 85.7% pain relief. Look at this lady, young lady. They removed a special meningioma from a special place. She had a glossopharyngeal pain and pain in the neck. What shall we do for this patient? I tried trigeminal tractotomy nucleotomy 2 times. Look at this. This is a cancer. How we will approach? It's necessary to making the lesions in the glossopharyngeal nerve and trigeminal nerve and C2 also. Is it located somewhere together? Yes. It is in the descending trigeminal tractus. If you make the lesions here, the patient will be less pain, without pain probably. This is the Wilder Painfield words. All pain can be relieved if it is really required by cutting the proper sensor nerves or nerve tract in the proper place at the proper time. For this reason, I insist that we are human. We are not the technician. Some cancer patient pains can be relieved by the neurosurgeons. As a result of this practice, the patient will gain the independence from the hospital. It is not easy to waiting list in the hospital. System and physician. Refilling is a problem. To asking waiting list is a problem in everywhere in my practice. This is chance for living life as a person, not as a patient. They are person. Thank you for me. You can ask every kind of question. No problem.
The microphone to Dr. Ian.
That's a very impressive talk, ablating the pain at the brain level.
Distracting pain.
Now, my specialty is in intraperoneal surgery. If you trace the source of the pain, let's say to the lumbar spine, the dorsal ganglion is an area that is causing pain. Do you predict that we can use some type of neuromodulation more at the source of the pain and at the brain?
I have a limited experience in this field. I don't know properly.
Pain generator.
But you can do it. If you smell the patients properly, before some animals smell the foods before eating, cats and dogs. If you smell the patients, you can succeed it. You can try it.
I have done that, and it's like
some of the people sending these kind of patients from the United States to me. The people are not using these in the United States. It is not so much popular.
These people are here to learn how to treat pain, and now there's another way to do it. If you get really good at identifying the dorsal root in the foramen, just exactly what you heard the speakers, you can modulate the pain before it reaches the spinal cord, and don't have to ablate the spinal cord or the brain at the dorsal horn. It goes from DRG to dorsal horn to the...
Oh yes, it's a possibility. One special indication for multi-operated disc, and I'm using this rarely. I still needs to learn. That's why I'm attending to the anatomy department.
Professor, that was a very excellent talk and very interesting CT pictures. I have a question for patients that have thalamic strokes and they have thalamic differentiation pain.
It is a central pain, I believe. I worked too many times for thalamic pain. I have limited group of patients. The thalamotomy is not work very well. One of the special authors described from the United States that medial thalamotomy is working. Stimulation, we tried stimulation, it's not worked well properly. It is not worked. And we made the capsulotomy. I asked this problem for the Dr. Sweet from Mass General Hospital. He died. Maybe we can use some of the seminal procedures.
Any questions? I think there's, as a question of Dr. Yang, always the patients are different for dorsal root ganglion and for the chordotomy. Maybe for intractable pain, or the dorsal root ganglion will be not enough. What do you think? Only distracting the dorsal root, of course, the pain anatomically is the first dorsal root ganglion, but in some patients it will be not enough. And Dr. Kanpolat says that is about the cancer pain, about intractable pain. What do you think about this?
I think with cancer, you have nothing to lose by doing destruction. What I do is I decompress and I neuromodulate. In other words, when I do a transfemoral block and I do a sympathetic block and the pain goes away, I don't want to destroy the nerve. I want to block the pain fight. And we now have technology that instead of an implantable spinal cord stimulator with a wire, we can put the electrode and then have a battery hooked up to the patient's belt that they can control. We've done some initial studies in Mexico. So I tell you this because this is going to be very big for the future. We're going to modulate, we won't destroy. We will block this pain signal. And if your injection can block it, the radio frequency can block it.
What do you think about spinal cord tumors?
I don't have any expertise in spinal cord.
No, so the patients are different, I think. I said about this question. Sometimes it's dorsal root ganglion, yes, but sometimes it should be chordotomy, yes.
Thank you very much for your
I'm
contribution.
talking about painful degenerative conditions of the lumbar spine, not tumors.
Oh, thank you.